Hello, everyone. Welcome to our evening seminar at the Breast Cancer Coalition. I see so far people are rolling right in. We've got about 70 so far, so we'll just kind of let a few people come in as I slowly start our introductions. Good evening and welcome. I'm Christina Thompson, and I'm the program director here at the Breast Cancer Coalition. I'm so glad that you could all join us this evening. Let's see, we're up to 175 participants who've come tonight to learn about COVID-19, the vaccines, and the impact on cancer survivors and those in current treatment. Before we begin the presentation, I'll just mention some Zoom tips. During this presentation, it is a webinar format, so all videos and microphones of attendees will be off, just to enhance the experience for everyone. Many questions were submitted ahead of time, and you may also enter a question in the chat feature, and Dr. Falkson will answer as many as time allows. I'm so excited to introduce our presenter this evening, Dr. Carla Falkson. She is the director of the Breast Oncology Clinical Research Program and Breast Cancer Service Line at U of R Medicine Wilmot Cancer Institute. She's also the medical director of Pluta Cancer Center. For 30 years, she's been actively involved in the development and planning of clinical trials, new agents, and genomic approaches to improve the outcome for patients with breast cancer. She's passionate about clinical trials designed to find and deliver new and improved treatments for breast cancer patients, helping current and future generations. Dr. Falkson is a wonderful friend of the coalition, and she has provided her expertise for evening seminars and our advanced breast cancer seminar. We are so grateful for the positive impact she's had on our cancer community, and we are excited to learn what cancer survivors need to know about the implications of COVID-19. So we're at about 206 people now. This is a wonderful turnout. I'm going to go ahead and turn everything over to Dr. Falkson. Welcome.
Thank you very much. I'm so honored to be here, and thank you for that very kind introduction. Ladies, and I'm not sure if I should say gentlemen, I'm very happy that you're all here tonight, because I think this is such an important topic and it's evolving all the time. So whatever we can do to educate ourselves, and that includes me too, I think is just great. So thank you for hosting this to the foundation. Thank you. I'm going to start my screen share. Have I done it correctly or not? Oh, can you?
I don't see it yet, Dr. Falkson.
Okay. I am having a little technical issue because I just see it, but I've lost my Zoom. So what do I do? How do I get back to Zoom? I think I must cancel it.
Let's see.
Let's see. End show. Go to Zoom and go to screen share. I apologize for my technical mishap.
You've got it now.
That's better. Thank you. So I know you all know, but it was around about December that the WHO started talking about and declaring COVID a problem. And in March last year, that a global pandemic was declared. Since then, everybody's lives have been turned upside down, and many of you are frightened. I think we're all frightened. Some are just more frightened than others. But now with the vaccines, I think at last light is at the end of the tunnel. And so I want to just go through a little bit about the vaccines, because I'd like us to focus on the positive, because we will all get through this, and it's just a matter of how we can get through it with the least trauma and morbidity, especially for our patients and families and friends who have cancer, and specifically breast cancer. So one of the main questions that comes up when you hear about a vaccine is how effective is it and how safe is it? I was going to run through a few questions. During my talk, I'll be looking at what are the vaccines that are being developed and which ones are near approval. What is the incidence and severity of COVID-19 in patients with cancer, and where should they be positioned in vaccination priorities? What is the ability of cancer patients to mount an immune response following vaccination? How effective will vaccines be in cancer patients? What is the risk of interaction of the vaccines with anti-cancer therapies? And what are the priority considerations to be implemented for patients with cancer so as to identify groups with varying benefits from a COVID vaccine? And I know there are many other questions from the audience, and so I'm happy to try to answer them to the best of my ability. And for some of the questions, I think we don't have answers yet, but we can address those as we get to them. So the WHO currently counts about 214 projects of vaccines in development, and 52 of these are already in clinical development. A variety of different technologies have been employed, and it's really remarkable that they have been so successful in such a short time. The technologies are multiple, but I just focused on a few because we've got the Pfizer and the Moderna vaccines here, which are based on an messenger RNA. So RNA is part of the protein signaling system in our cells, and they take a little piece of the RNA that is targeted to part of the virus. The virus is basically, if you think of it as a circular organism, or just think of a little sphere, and it's got like little spikes on it. So they target these spikes. And then this messenger RNA is placed inside a little fat globule, and that is basically the vaccine. Another technology is when a virus is taken and weakened and used as a carrier or a vector for something that is antigenic that will create an immune response in the patient when you're, or in the person when you're injected. And then there are other technologies using other methods such as plasmid DNA vaccines and long viral peptides, and a lot of technology and technical issues that I'm not going to go into detail right now. So let's look at what we have and how effective are they. And this is some of the good news, because we have the Pfizer and the Moderna vaccines. They are, as I just mentioned, mRNA-based vaccines, and they've shown over a 90% protection from COVID and are very well tolerated. There's another vaccine. It's a non-replicated adenoviral vector-based vaccine. It's actually a chimpanzee adenovirus that is used as the carrier substance. This was developed between Oxford and AstraZeneca. And this has also shown very good protection rates of anything between 62 and 90%, depending on what dosing regimens were used. More recently, 2 other vaccines have also come to the market, for emergency use authorization by the FDA. And these 2 vaccines that show promise are Novavax. It's a slightly different technology, demonstrating an 89% efficacy, and very optimistic and promising to note that it was shown to be effective against some of the variants, specifically the UK and the South African variants. Then another vaccine is Johnson & Johnson's vaccine. Again, this is a human adenovirus vector vaccine, was 72% effective in the US and 66% effective overall at protecting moderate to severe COVID. Some of the differences between these vaccines have been in storage requirements. The Pfizer vaccine needed to be stored at a much lower temperature than some of the others. And some of the doses and schedules are slightly different. So these are operational issues. And then how to make sure that patients actually get the second dose. There are also clinical trials going on looking at whether it would be more effective to use two different types of vaccines. In other words, say, for example, start with vaccine A, and instead of giving a second dose of vaccine A, give a vaccine B. These results we don't know yet. I'm trying to see, I'm sorry to interrupt myself, but this there was something popping over the screen from the screen share. So in the forefront of all our minds is what is the incidence and severity of COVID-19 in patients with cancer, and where should they be positioned in vaccination priority policies? Unfortunately, patients with cancer as a group have been shown to be at higher risk of severe COVID-19. Amongst patients with cancers who have cancers of either lung cancer or hematological type, in other words, leukemias, or patients who have got metastatic disease, in other words, stage 4 disease, we see a persistently increased risk of severe COVID. Patients with solid tumors appear to suffer an increased risk, particularly in the first year after diagnosis, but then it drops to baseline if the diagnosis is more than 5 years ago. For any kind of malignancy, active disease, in other words, active malignancy, confers significantly increased risk of severe COVID-19. However, the higher incidence and severity of COVID-19 in patients with cancer, as opposed to those without cancer, are observations based on non-comparative retrospective studies. Data on the true incidence and direct comparison remains elusive. Most studies do not have the full denominator to calculate the true incidence. And when we're doing studies and looking at patients with disease and trying to discern which elements of the disease are more important, some factors such as other comorbidities also play into the role. So if you're young with cancer, your prognosis may be less severe than if you're old and weak and have chronic obstructive airways disease and heart disease and diabetes and are obese and also have cancer on top of all of that, for example. Now, something that is very near and dear to myself and to many of my colleagues is that the SARS-CoV-2, the COVID-19 pandemic, is resulting in significant and devastating delays in screening, diagnosis and treatment, and monitoring and surveillance strategies in patients with cancer. And we're really concerned that ultimately we're going to see a tsunami, I think was what one of my colleagues said recently, of breast cancer, for example, because of decreased screening and managing just to care for your cancer the way we would normally want to. There's also been a significant impact on clinical trials, and patients have not been participating, and this has been just detrimental, and it is unfortunately hard to measure, and we're trying to correct this. So let's look a little bit about just vaccinating patients in order to get, and not just patients, but people, in order to improve herd immunity and try to get the pandemic under control once and for all. So Unfortunately, there's a paucity of evidence looking at cancer patients and COVID vaccines. The large trials excluded patients with active cancer. So although the evidence regarding vaccination in patients with cancer is limited, there's enough evidence to support the anti-infective vaccination in general, or the anti-infective effects of vaccination in general, excluding, of course, vaccines that are live. We generally don't want to give patients who are immune compromised or who have cancer a live vaccine. So one would want to stay away from the AstraZeneca vaccine, but the Pfizer and the Moderna vaccines, for example, will be absolutely safe. Patients with cancer have an increased risk of severe COVID, we just said, specifically hematological malignancy, who require chemotherapy, or advanced solid tumors, or a history of a solid tumor less than 5 years ago. But they should be vaccinated against COVID. I sometimes use the SARS-CoV-2 and sometimes COVID-19. They're interchangeable. These people should be vaccinated regardless of any other indications and positioned high in prioritization for getting the vaccine. And this is irrespective of age. This second paragraph is a little bit about patients who don't have breast cancer, so perhaps I'll just skip over that. If we look at what we know about vaccinating patients with cancer, we know quite a lot about influenza vaccines and that they are effective and have been shown to make a dramatic difference and are quite safe. And so based on data extrapolation from other vaccines and mechanism of action of the COVID-19 vaccines that we have, that I've just mentioned, but not the live ones like Moderna and Pfizer, which are okay, it is conceivable that the efficacy and safety of vaccinations against COVID-19 may be estimated to be similar to that of patients without cancer. But of course, data from clinical trials are lacking. And so this still remains a question. But beyond stem cell transplantation, the efficacy of COVID-19 vaccines can also vary in patients with distinct contexts of malignant disease type, tumor type, disease extent, intrinsic or therapy-induced immunosuppression. However, experts throughout the US and Europe agree that the benefits of vaccination seems to significantly and substantially outweigh the risks. So the message is, yes, everybody should get vaccinated. Whenever possible, the administration of the vaccine should be performed before the initiation of chemotherapy. But in patients who have already started chemotherapy, the existing data do not support a specific timing of administration with respect to chemotherapy infusions. And I know there were several questions from the audience about what's the best timing. And after looking at all the information and all the data, experts have agreed that it's both a cellular and a humoral immunity that is developed and stimulated by these vaccines, and that there's no better timing to administer the vaccines if patients have already started chemotherapy. So the efficacy and duration of immunity in patients with cancer is still unknown and unexplored. And given often immune compromised status and the frailty of these patients, the experts suggest monitoring in the context of registries and dedicated clinical trials. And these are recommendations from American Society of Clinical Oncology and the European Society of Medical Oncology, who have got registries for practitioners and providers to participate in, so that we can gather more information, so that we can increase our information and everybody's knowledge about what is the optimal way to proceed. Despite getting vaccines, it has to be emphasized that physical distancing measures masking, face shields and sanitizers, hand washing and other hygiene methods are still required during the pandemic, including for patients with cancer, and should certainly accompany vaccination strategies. So let's look a little bit more in detail about what is the ability of a cancer patient, or what kind of ability do cancer patients have to mount an immune response following vaccination. So as I said before, data is scarce, and it's mainly based on what we know about influenza vaccination. Observational clinical studies indicate that lower mortality and morbidity rates from influenza are observed in cancer patients receiving influenza vaccine. So this suggests an efficient immune response. Accumulated evidence from influenza vaccinations suggests that patients with cancer are able to mount a protective immune response from an anti-COVID vaccine, though the level of immunity may be modulated by a range of factors: type of malignancy, antineoplastic therapies, timing of administration, and pre-existing immune dysfunction, and other factors such as fitness. And data on the interaction of such factors with vaccine-induced immunity in patients with cancer are needed. Healthcare workers caring for patients with cancer with increased risk should be prioritized in order to minimize what we call nosocomial transmission. Nosocomial is the technical term for an infection that you acquire when you're in the hospital. Vaccinating healthcare staff against influenza has been shown to reduce hospital-transmitted or nosocomial transmission of infection in cancer care. Furthermore, certain immune-compromised cancer patients might not achieve sufficient immune response to vaccination. So if the healthcare staff are vaccinated, this would protect these patients further as well, and further provides a rationale for prioritizing healthcare workers getting vaccines. Now, there are some ethical debates about what is best for the individual and what is the individual's right to choose, and what is the society's position on all of this, because some people don't want to receive the vaccine and feel they can refuse. And that's a topic for a separate talk completely. So what is the risk of interaction of one of these COVID vaccines with anti-cancer therapy? So unfortunately, none of the COVID vaccine trials that are enrolling patients had patients with immunosuppressive therapy. But data from some patients with cancer have been accrued. Most of the trials required patients to be off immunosuppression for a certain time period before they were eligible for the vaccination. So we know live vaccines in general are contraindicated in patients undergoing immunosuppressive therapy. And this is based on data gathered over many years of live attenuated virus vaccines. An example is the polio vaccine. Polio vaccines are highly effective against polio and preventing polio, but occasionally a very rare situation occurs where one of these vaccines, if it's a live vaccine and the patient is immune compromised, has been shown to cause some illness. And so in order to be completely cautious and safe for our patients with cancer who are immune compromised, we advise against getting live vaccines. Retrospective data sets suggest good tolerability and safety of influenza vaccines in patients with cancer receiving immune checkpoint inhibitors, as well as patients on cytotoxic therapy or targeted agents. A lot of our patients with breast cancer are receiving hormonal therapies or endocrine therapies. And while these therapies may make you feel miserable, they don't actually influence your immune system, so you're completely safe to get the vaccine. Although no obvious safety concerns are evident, there's clear need to generate data on preference of vaccine technology and interaction of the COVID-19 vaccines with antineoplastic therapies in patients with cancer, potentially impacting efficacy, dosing, or toxicity by in-trial, post-trial, and registry monitoring. So what are the priority considerations to be implemented for patients with cancer so as to identify groups with varying benefits from a COVID-19 vaccine? Vaccination strategies have been published worldwide in order to prioritize vaccine administration in the different populations. The World Health Organization considers the elderly and healthcare professionals as first priorities, respectively phases 1B and 1A, and cancer patients are positioned in phase 2. Here in the United States, professionals are considered priorities 1A, followed by cancer patients and the elderly being 65 years and older. Just as a matter of interest, for those of you who want to know, Australia, professionals with comorbidities such as cancer in the elderly are first priority. In Europe, the UK and France, they base their recommendation priorities on age before comorbidities such as cancer. Belgium, Luxembourg, and Sweden will vaccinate in priority cancer patients and healthcare professionals. And Germany issued a joint paper, groups of persons who have significant increased risk of serious or fatal disease are prioritized. And I just want to emphasize again that patients with cancer do not represent a homogeneous population. So we see young people with cancer, we see old, frail people with cancer. So we also have to take that into consideration. So in general, cancer, or patients with cancer can be sort of classified into 3 pathways or 3 areas. Those who have got active disease on treatment, those with chronic disease after specific treatment, and patients in the survivorship phase. So in the survivorship phase, previous studies revealed a high risk of complications related to influenza in cancer patients compared to a cancer-free control cohort, specifically in hematological cancers. Consequently, vaccination seems essential to protect survivors, along with patients in the chronic phase of their cancer without active treatment. The question is more uneasy in patients with active disease on anti-cancer therapy for whom vaccination could have reduced efficacy or adverse events. In other words, if you have active disease, getting active therapy, is the vaccine as effective as it would be in somebody who does not have cancer, is not getting therapy? And Dr. Fauci actually was quoted as saying, even if it's only 50% effective, at least it's better than nothing. Additionally, there are no granular data that dissect the vaccine role in protecting from COVID-19 and protection of SARS or COVID transmission in patients with cancer. So I'm happy to report that the most recent data that I read was that the acceptability of COVID-19 vaccination here in the US has reached about 69% amongst adults. If their healthcare provider recommends it. Informed consent and shared decision making should be the rule to discuss the benefits and risks of the vaccination and to prevent patients from double jeopardy, cancer and infection. In addition to talking to your provider or your health or your oncologist or whoever you are, medical professional you're seeing, there are some websites that are also very useful and can also guide you to places where you can sign up for the vaccine. I've listed them here. The first one is one of University of Rochester Medical Center's sites. It's vaccine.urmc.edu. The second one, flvaccinehub.com. And the third one is the New York State, because each state has slightly different regulations of rolling out the vaccine to their populations. But COVID-19 vaccine.health.ny.gov is our New York State's website. And then, of course, the CDC's website. And then I put a long website there, just also back to Rochester's website about cancer and COVID-19 vaccine and what cancer patients should know. There are many experts much smarter than me, so I'm really honored that you're all listening to me tonight, but many experts who are infectious diseases experts and vaccine experts who have come together and are continually coming together, putting out guidelines and making recommendations on what to do. Here in the United States, the NCCN, the National NCCN guidelines are guidelines that we as oncologists try to follow, because these set standards and standard of care and best practices. And the NCCN put together a panel of experts and came up with some guidelines for cancer and COVID-19 vaccinations. And I try to summarize some of it here, but essentially I will just tell you that patients with breast cancer should go ahead and have the vaccine when it's available to them. It's only patients who've got leukemias or some of the hematological malignancies where there should be a delay. And it's so important for caregivers and household people and close contacts to also be vaccinated, because that way the chances of giving it to a near and dear loved one who has cancer is minimized. So we're protecting each other by getting vaccinated. And that's the way we build herd immunity, because the less people or the more people are vaccinated, the less people will get COVID. And the less COVID is transmitted from person to person, the less chance that virus has of becoming mutated or of these variants developing, because the variants is a changed virus that may be more infective and maybe even worse than the original one. There were some questions from the audience about radiation and getting vaccinated. And certainly, even if you're having radiation, get the vaccine when the vaccine becomes available to you. What about major surgery? The recommendation is from the NCCN that it should be separated by a few days between surgery and vaccinating. And the primary reason of avoiding the vaccine immediately in the perioperative period is so that symptoms such as fever can be correctly attributed either to surgery versus the vaccination. For more complicated surgeries, so for example, when a spleen gets taken out, which could lead to an immunosuppressive states, surgeons may specifically make separate recommendations to increase the window from the time of vaccination. So again, to summarize, COVID-19 vaccines should be prioritized over other needed vaccines, as data on dual vaccination are not available at this time. And the recommendation is that 2 weeks, 14 days should be waited, or a gap should be kept of about 14 days between a COVID vaccine and other approved vaccines. But discussion with clinical trial leads should be considered in advance to prevent protocol violations or exclusions when going for these vaccines. There were many questions about timing of chemotherapy and white count being low. And so I thought I would put up a few of these recommendations from the NCCN. Specifically, the NCCN's expert committee recognizes that granulocytopenia, that's when the neutrophils, or that absolute neutrophil count, ANC, that you get checked so regularly when you're getting chemotherapy, that does not in itself significantly affect immunologic response to vaccination. It is used in this setting of profound immunosuppression for patients with hematological malignancies as a surrogate marker for recovery of adequate immune competence to respond to vaccines and sufficient platelet recovery to avoid bleeding complications from intramuscular administration. And I think this is not so much relevant to our breast cancer community as it is to people who have leukemia. In our breast cancer community, generally, periods of neutropenia are very short, and so it's not used for timing of vaccination. In patients receiving chemotherapy, optimal timing of vaccination in relation to cycles of chemotherapy is unknown, was the statement from the NCCN expert committee. And given the variability of specific regimens and intervals between cycles, it is not possible to state whether immunization will be more effective if administered at the time of chemotherapy administration versus mid-cycle, when the white blood count might be at its nadir or the lowest. And in the absence of data, the NCCN expert committee recommends vaccination when available. Theoretical risks of exacerbated immune-related adverse events in patients receiving immune checkpoint inhibitors may exist, but there are no data on timing of vaccine administration. So this may be considered on the same day as the immunotherapy for convenience and to reduce added visits to the office when possible. I'm going to jump over this, but just to say that there are slight variations in recommendations for patients who have other diseases, people who, for example, have had bone marrow transplants and have graft versus host disease, or patients who have got lymphomas and are getting treatments like rituximab. But since this audience, I think, is focusing on breast cancer, I'm going to skip that and move on to questions. If anybody has questions that they would like me to address at this point.
Dr. Falkson, we have had some questions pop into our chat regarding GYN cancer survivors. Can you speak to them as well as the breast cancer, and is anything different for that population?
I think insofar as we can lump GYN cancers with the solid tumor classification, I think you could put them into that same group. It's really the hematological or the blood cancers, so the leukemias, that type of cancer that's separate. Was there a specific question about a gynecological malignancy? That more specific that I could address?
Well, we had one question about uterine cancer and just what the concerns would be. Would they be any different?
No, it would be the same as with breast cancer.
Mm-hmm. Okay.
I know there were some questions about mammograms and timing of mammograms.
Yes.
And I really think that there was a while when the pandemic shut everything down that we were very distressed because screenings of breast cancer stopped. And so I'd like to encourage everybody to go for their screening. But the breast cancer, not breast cancer, the screening group did come out with a consensus statement to say that it's very rare, but somebody who's had a vaccine could have an enlarged lymph node. So perhaps have your mammogram just before you have your vaccination, or otherwise wait a few weeks after the last vaccination before you have your mammogram if you're worried about that. But don't postpone getting a mammogram if it's critical to making a diagnosis, because as I've mentioned at one point, it's this double jeopardy. You don't want to have cancer and COVID. So, if there's a doubt about whether you should have the mammogram or postpone it, check with your provider.
We have a question about Prolia as a treatment for osteoporosis. It can cause immune suppression. So then would you have a less than normal response to the vaccine? Would you recommend waiting?
No, I wouldn't worry about Prolia. I think that's fine, completely fine.
So we've had some questions about when applying for a vaccine, we are asked about whether or not we received radiation. So just wondering what the correlation is there.
It's quite safe to have the vaccine when it's available. And I don't know why they're asking about the radiation.
Now, if someone has had COVID recently, say 6 weeks ago, how long are they immune for? When can they receive their vaccine?
I have to confess, I did read the other day about how soon after COVID you can get the vaccine, but I cannot exactly remember. I would have to verify that. But I'm sure if you inquire about getting the vaccine, the authority administering the vaccine would check with you when you had it. Sorry.
Should you get the vaccine if you're taking prednisone for a period of months?
So that's one of those sort of slippery areas where you're immune compromised because of the prednisone, and you may not be mounting as good a response as somebody who's not taking the prednisone, but it's not dangerous. And as I just earlier on quoted Dr. Fauci saying, some immunity is better than none. So the answer would be yes.
So we've got a question here. Are cancer survivors at greater risk for complications if they get COVID-19, especially if they've had lung damage due to radiation or heart damage due to a chemotherapy and or radiation?
So the answer is yes.
Let's see, I would like to know the recommendations on administration of the vaccine. Where should you get the shot if you had lymph nodes removed? Can you get both doses in the same arm?
Again, I believe the answer is yes. This would be based on extrapolating information from the influenza vaccine, where patients have been safely immunized after having lymph nodes removed, but there have been case reports where there have been some problems. So if you have the option of having the vaccine in another arm, have it in the other arm, but if you've had surgery on both sides, then it's okay to still go ahead and have it.
Okay. And just to reiterate something that you said earlier, we should not get other vaccines like just the normal influenza until there's more data?
No, there should just be an interval of about 14 days is what the recommendation is between that. So absolutely, yes, please get the influenza vaccine, because before the COVID pandemic, it was in 2009 that the WHO declared the previous pandemic of an H1N1 flu pandemic. So get the flu vaccine, but just give yourself 2 weeks between flu vaccine and COVID vaccine.
Okay. Do you have a preference between either the Pfizer or Moderna vaccines? And then we've heard that the Johnson & Johnson will be coming as well.
No, I don't. Just whichever one comes up first.
Any concern if we've got someone taking an aromatase inhibitor?
No, none at all. Absolutely none.
And what about those who have had lymphedema?
Well, I think you would prefer to have the vaccination in the arm that doesn't have lymphedema. And hopefully you don't have lymphedema in both arms. If that is the situation, then I think you should talk to your provider to figure out if it's still safe to get it in that arm or whether some other site should be selected. It needs
Is
to
that
be.
an option that we have to have it in a different site?
Well, you know, it's an intramuscular injection, so it just happens that the arm is easy to reach. So theoretically, it doesn't have to be in the arm, in the deltoid muscle. It could be in any muscle.
Okay. And that might be a better alternative for somebody concerned about the lymph nodes,
Well, I think
concerned about.
they should talk. They should, if it's really not possible in the arm, then they should talk to their provider.
Okay. I have a question about allergies. I couldn't get the mRNA vaccines due to PEG and polysorbate 80. Are the others okay?
I think we would have to double check that. If the person asking the question is getting active therapy, and there's any concern about immunosuppression, then not a live vaccine, but then perhaps one of the other non-viral vector vaccines would be okay. But I'm afraid I can't give specifics. They'd have to check exactly once those vaccines become available, what the contents are.
Do you know if Pluta will be offering the vaccine to its vulnerable population like the MSK is doing in New York City?
At this stage, we don't have any plans to do that, unfortunately, but things change all the time. So,
do you know if the vaccine will worsen any neuropathy that we experience after chemo?
I do not believe that it will. There's no indication from any of the trials and patients who have been vaccinated so far that it has any effect like that.
Okay. Are cancer survivors who are years past treatment still eligible to receive the vaccine, now under the 1B group?
That is a good question. And I think once you are beyond 5 years of your diagnosis, the data suggests that you're out of that high risk or high risk group. But I think it would depend on ultimately the way the state is administering or selecting people, because you may have other high risk factors such as age.
Okay. Do certain people with blood types like an O negative have a less likely chance of getting COVID? If they do get it, would their symptoms be less severe?
Well, there were some studies published about that. And the suggestion was that, so very simply put, if you've got a blood type A or blood type B, it means you've got a specific antigen, and blood type O doesn't have A or B. So if you're blood type O, then you may have made antibodies against type A and B, or A or B. And the same with the rhesus blood type, which is the positive or the negative. So if you're negative, then you might have some antibodies against the positive. And the hypothesis was that perhaps some of these antibodies against AB or the Rh factor could have some cross-reactivity against the COVID virus. Because there was some suggestion that perhaps people with blood type O, and specifically O negative, would have less severe COVID. And why would that be the case? And they thought, well, perhaps it's they've got some kind of natural immunity or some kind of antibodies. But I did read those articles way back last year, and I haven't read anything about them since. So I don't know if that's been validated or confirmed going forwards.
As cancer patients were not included in COVID-19 vaccine trials, questions exist about vaccine safety for those with lowered immune responses due to cancer treatments. Do you have any studies or data that we could look at with that?
So as I presented, unfortunately, no, there's a paucity of data in patients, cancer patients on treatment. Safety-wise, there's no reason to think that any of the mRNA viruses or any of the non-viral vector viruses would be dangerous. They would all be potentially should be safe. Hypothetically, you could say, well, perhaps the mRNA viruses could go and locate in the tumor and cause some difference there. So we will continue to gather data and collect information. But at the moment, the apparent risk of getting COVID outweighs any of those risks. So I would say the benefit of taking a vaccine is so high that I would encourage people to do that.
Okay, we have one that just came in. Does the vaccine impact fertility in women?
No. There was some urban legend down in New Zealand or somewhere about that, and I don't know where that started because there's no suggestion that it would do anything like that.
Okay. And you mentioned that someone with leukemia should delay getting the vaccine. What about lymphoma?
There are so many different kinds of lymphomas. So some lymphomas are low grade and have a really good prognosis, and others are high grade and much more like a leukemia. So I think the best would be to talk to your oncologist who's treating your lymphoma. But yes, some of the lymphoma treatments like Rituxan can impact the vaccine. So specifically, if you have lymphoma, talk to your provider, your oncologist provider.
Is there any evidence for whether having received a PD-1 inhibitor in the last year could make COVID infections itself more severe?
So PD-1 and PD-L1, these are the checkpoint inhibitors that I was talking about earlier on. And the checkpoint inhibitors, very simplistically put, take the brakes off your own immune system. So one of their side effects is inflammation, and it could be theoretically inflammation of any organ. And so this is a valid question and a valid concern, but there doesn't appear to be a problem with the vaccine.
Okay. Is the vaccine recommended for those with genetics tied to their breast cancer?
Yes, it's for everybody.
Right. If highly allergic to tetanus and told that I have encapsulated, should I still get the vaccine? Encapsulated TB.
Encapsulated TB.
Encapsulated.
It shouldn't be a problem for the vaccine at all. I confess I would have to go and check why the person is very allergic to tetanus. I don't know, but if it's any of the substances that are in the vaccines, then that could be a concern for cross-reactivity. That person would have to check with the New York State or whoever is administering the vaccine. I'm sorry.
How important is the span of 14 days between the two vaccine shots? Would 3 weeks between be just as effective?
Well, the 2 weeks was a recommendation for getting other types of vaccinations, not for the COVID. So if you have to get a flu vaccine, the panels were recommending you wait 2 weeks between getting a COVID vaccine and a flu vaccine. But the COVID vaccines, the Pfizer schedule at the moment is that you get the first vaccine, if that's day 1, then 3 weeks later, 21 days, you get your second vaccine. And for the Moderna, it's 4 weeks later, so 28 days later, you would get that vaccine. And looking at the graphs in the studies of how the patients who were being tested, or the vaccine was being tested on them, how their antibodies built up. After about 10 days, they started developing antibodies against the Pfizer and also the Moderna vaccination. And the antibody titer or levels in the blood kept going up and up. And then with the Pfizer, they were given a booster 3 weeks later, and then they saw the rate of antibodies went up even further, and it seemed to sort of reach a peak around about 2 or 3 weeks after that second injection. I hope that answers that person's question.
Are there any active safety and efficacy trials for cancer patient responses to the vaccine?
So there are these registries, but I'm not aware of any other. No, I don't know. Sorry, I just know about the registries.
Any concerns with an allergy to amoxicillin with getting the vaccine?
No, not that I'm aware of.
It really sounds like there's very little keeping us from getting the vaccine, Dr. Falkson.
Yes, I really think we should all get the vaccine.
I think we're answering these questions here. All right, can you measure degree of immunity conferred for those cancer patients who receive the vaccine?
Can you measure the degree of immunity? Well, I think what the person is asking, can we measure antibody levels and say you're immune or you're not immune the way we would, for example, with if you get a hepatitis B vaccination? And the answer is not really. It's difficult because measuring the antibodies hasn't completely been standardized everywhere. So if you have a level of antibodies checked at one laboratory, it may not be exactly the same as somewhere else. So at this stage, at this time, our technology, I don't believe, allows for that kind of evaluation. It may change.
Right. And this kind of ties into another question like it. How long is a COVID vaccine good for? Is it a lifetime vaccine or will it be needed again in the future?
That is an excellent question that a lot of very smart people have been asking, and we do not know. It may be that we need to get booster vaccines. It may not be. It may be fine, may be good for years, but it may be one of those that we need to get a booster periodically.
Mm-hmm. I do believe you talked about it as well, the variants and the mutations that we're seeing. And these current vaccines that are out, is that protecting us from those?
There's suggestion that we are getting protected, yes, from the current, certainly from the UK and the South African variants. I just read in the news that some people in California were reporting a variant there, but it hasn't been peer reviewed. So I don't know how accurate that information is, and I don't feel comfortable, making comments on that at this stage. Unfortunately, I think this is such a dynamic, evolving field. But I can just again emphasize that if we could build up herd immunity, and the best way to build up herd immunity is to get everybody vaccinated, then the virus can't divide. And if it can't divide, it can't make variants. And so that's, again, another reason to get vaccinated.
What role does vitamin D play in our immunity and protection against COVID-19?
It's not been established, but vitamin D is important for your bone health. And so especially up here in the north, we don't want to be vitamin D deficient.
Right. And does that have any a specific level to recommend for cancer survivors at all?
blood level of vitamin D.
Right.
Again, there's some controversy around that, but the general recommendation is to get in approximately in the order of about 2,000 international units of vitamin D per day.
If you have a bout of cellulitis in an arm with lymph nodes removed, is it a concern? And if not, how long should you wait before getting the shot?
Again, that person, hopefully that's only one arm and not both arms. But yes, cellulitis certainly is always a concern, and especially if the lymph nodes are removed. So if possible, get the shot in the other arm.
Or another muscle like we discussed earlier.
Yeah, or talk to your provider about getting it in another place, yes. And it's probably just coincidental. I really don't believe that the vaccine could cause cellulitis. And the vaccine, when they give the injection, it's an aseptic technique. So it's not as if they're jabbing a dirty needle into your arm. They clean the area properly. So the risk of getting a bacterial infection, which is what cellulitis is, from a vaccination would be incredibly, incredibly small.
I've had a few questions come in regarding the slides, and Dr. Falkson has graciously agreed to provide those to us. So we will be sending those out, as well as the YouTube recording of our session tonight, within the next few days to everybody who's registered. So those will definitely be provided. Those will have the links in there as well that she showed us for registering for the vaccine. And we've got some lovely comments. You are amazingly knowledgeable. Thank you, Dr. Falkson.
Thank you so much. Thank you.
Okay, so I've got one here. This was asked previously, but it was asked, but we're going to ask something similar, different a little bit. The current vaccines by Pfizer and Moderna supposedly provide 94 to 95% protection. Is that protection against all COVID disease or against severe disease and hospitalization, as the upcoming J&J vaccine claims?
You know, this is a very, very good question. So the way they reported protection, when I read the papers, the number of patients who actually got COVID on the placebo arms was much larger than the patients who got COVID. And yes, they were severe COVID, and then how many deaths. So I think it's almost a word play about, what are we being protected against? Well, if I get protected and I have a very, very mild case, I think that's protection. But I understand you don't want it at all. So was that Johnson & Johnson who claimed that against the others?
Mm-hmm.
I think they're all effective. Some seem to have less incidences of severe COVID, and if they do have COVID, I'm sorry, I'm not sure how to answer that question, except to say that I think it's the different companies are now trying to vie for who's got the best vaccine, and they all seem to be pretty good. I don't know that one is less efficacious than the other. So Perhaps you can send me that question and I can read it and think about it,
Okay,
how to answer it.
I will do that. Okay. Lots of thank yous and how wonderful this presentation is. We have somebody who says they feel 100% better, so thank you.
Good, good. Yes, I know we're all under stress, and as I said in the beginning, we're all frightened. Some are more frightened than others.
Right.
And there are lots of online strategies to help relax and meditate and maybe do yoga. And thank you again to the BCCR for organizing this, because I think this is tremendous to just bring people together and give us a sense of community, because that's part of what the pandemic has done. It's ripped the community's sense of feeling together, and we're here to support each other. And so thank you. I really appreciate it.
We've got another question. Is there proof that drinking a lot of water before getting the shot helps?
No, just drink water to maintain hydration. That's good anyway.
Right. Great. Well, these are really wonderful questions, and we also just have such a great turnout today. Amazing. So keep the questions coming if you still have any. A lot has been covered, and like we said, both the slide PowerPoint and the YouTube link of the recording will be available. Yes, so we did talk about the radiation. If you don't mind, just briefly again, if we were previously had radiation, are we at a higher risk for a complication with COVID?
And the answer is no.
Good.
But again, I think I'm talking about breast cancer and the kind of radiation you would get for breast cancer. So there may be an exception, but the only way that I could think that an exception would occur is if for some reason you had significant lung damage, because people who have lung damage or chronic obstructive airways disease or any kind of lung disease are also at increased risk of getting severe or having problems with COVID complications.
Do you mind?
Sorry.
No, go right ahead, please.
I was going to say, nobody asked about complications, but I guess everybody knows that it's, I had a little sore arm, but I didn't have anything else. But people can have some fever, and occasionally you can have a swollen lymph node. But generally the vaccine is really well tolerated. With my second vaccine, I wasn't even sure she gave me something, because I said I couldn't even feel it.
Wow.
My arm was a bit painful for about 24 hours, but nothing else. So I can really, from personal experience, encourage people to go out and get it.
That's wonderful. It looks like we've really gone over most of the questions. And again, if you do have anything that you need, you can always send me an email. So that's Christina@bccr.org. And I would like to just say a big thank you to everyone who's attended here tonight, but also thank you, Dr. Falkson, for sharing all of this information and your time as well. We really appreciate it.
My pleasure. Thank you.
Thank you. We'll go ahead and just end things here.